In 2019, a 67-year-old man enrolled in a clinical study at the Human Nutrition Research Center at Tufts University in Boston. His systolic blood pressure had been sitting at 148 for the better part of 2 years. His cardiologist had already written the prescription, lisinopril, standard protocol, nothing unusual. Before he filled it, he agreed to participate in a 6-week dietary intervention. He changed one thing only. Not his diet, not his exercise routine, not his sleep schedule, not his sodium intake, at least not as part of the protocol. One ingredient added to water 3 times a day. 6 weeks later, his systolic pressure had dropped by more than 7 points. His cardiologist asked what he had changed. He handed her a tea bag. "I'm Dr. Jessica Ward. I've spent 15 years in cardiovascular and cardiometabolic research, reading the literature, tracking clinical trials, following the mechanisms as they get published. What I want to talk to you about today is something most people think is boring: water. Specifically, what you're adding to it, what you're not adding to it, and one ingredient that a substantial body of peer-reviewed research has been quietly building a case for well over a decade now, that almost nobody is discussing in the context of meaningful blood pressure management. If your blood pressure is creeping up and you're watching that number with the same quiet dread that most people in your situation feel, that sense that you're becoming a statistic waiting to happen, this is for you. If your cardiologist has mentioned medication and you want to understand what the non-pharmaceutical options actually look like based on controlled trials, not testimonials, this is for you. If you've already had a scare last month and you want to do something now, today, that the research supports, stay with me. I'm going to walk you through what the peer-reviewed data actually shows. Not what a supplement company tells you, not what a wellness influencer guesses, what the randomized controlled trials measured, what the mechanistic research explains, and how you can start this protocol for less than 30 cents a day. But first, I want to be crystal clear about something before we go any further. Everything I'm sharing today comes from peer-reviewed research. It is educational content. It is not medical advice. If you take blood thinners, statins, blood pressure medications, or insulin, please talk to your doctor before changing anything in your routine. What the literature shows and what's right for your specific physiology are 2 different conversations. I can give you the first. Your doctor handles the second. Now, here's what I need you to hold in mind for the next few minutes, and I'm asking you to hold it specifically because your first reaction when I reveal the ingredient might be to dismiss it based on what you think you already know. The ingredient that dropped that Tufts participants' blood pressure by more than 7 points is not a supplement. It is not a pharmaceutical. It is not expensive. And when I finally name it, and I'm going to make you wait about 5 minutes because the mechanism is what makes the reveal actually mean something, you may have one of 2 reactions. Either, "I've actually heard of that," or "That cannot possibly work." Both reactions are understandable. Neither one is a substitute for looking at the data, because the research does not care about your priors. Let me show you what it found. One more thing before we go into the data. I know some of you are watching this because your doctor told you your blood pressure is borderline and they want to watch it for a few months. I know some of you got a reading last week that made your stomach drop. I know some of you watched a parent go through a stroke or a cardiac event and you carry that memory into every single blood pressure check. That fear is rational. It is also actionable. This video is about what the actionable part looks like at the level of the literature. 5 things. I want to show you 5 things in this video. What the 4 strongest studies actually found, how the mechanism works at the molecular level, why the most popular healthy drink at your grocery store is likely making your blood pressure worse, what a complete, affordable protocol looks like based on all of it, and what numbers to track to know whether it's working. Let's start with the evidence. Let's start with blood pressure as a mechanical problem because most people interact with it as a number on a cuff. And that framing creates a passive relationship with something that has an active biology underneath it. Think about the water pressure in a house. If the pipes are narrow, if the pump is working too hard, if there's too much water volume trying to move through a fixed size system, the pressure goes up. Too much pressure stresses the pipes at every junction. Over time, it damages the weakest points, connections, bends, thin sections of tubing. In your cardiovascular system, those weakest points are in the arterial walls of the coronary vessels, the cerebral vasculature, the microvasculature of the kidneys. High blood pressure does not feel like anything for years, and then, all at once, it does. Stage 2 hypertension, systolic at or above 140, is associated in the epidemiological literature with roughly a 3x increase in major cardiovascular event risk compared to optimal blood pressure. This is not a soft association. Every 20 mmHg increase in systolic pressure approximately doubles the risk of a cardiovascular event across the age range that matters most, 40 to 69. These numbers are from the Lewington 2002 meta-analysis published in The Lancet. 61 prospective studies, nearly 1 million adults. The precision of that risk relationship is why cardiologists treat the numbers seriously. The standard pharmaceutical answer to this problem is the ACE inhibitor, lisinopril, enalapril, ramipril, perindopril. These drugs work by blocking the angiotensin-converting enzyme, a protein that plays a central role in a hormonal cascade that tightens blood vessels and promotes sodium and water retention. Block the enzyme, the vessels relax, the volume decreases, the pressure drops. These medications are genuinely effective. The clinical evidence behind them is unambiguous. In mild to moderate hypertension, a typical ACE inhibitor will reduce systolic pressure by 8 to 12 mmHg. For people with heart failure, diabetic kidney disease, and established cardiovascular disease, the mortality benefit data is among the strongest in all of internal medicine. I'm not here to argue against ACE inhibitors. I'm here to show you what is running in the research alongside that pharmaceutical story. Diane L. McKay and her colleagues at the Jean Mayer Human Nutrition Research Center at Tufts published a randomized controlled trial in the Journal of Nutrition in 2010. The participants, 65 adults with pre-hypertension or mild hypertension. None were taking blood pressure medications. They were randomized to one of two conditions: 240 milliliters, about 8 ounces, of brewed hibiscus tea 3 times per day, or a placebo beverage with similar color and flavor profile, designed to be indistinguishable from the hibiscus tea. 6 weeks. At the end of 6 weeks, the hibiscus group showed a mean reduction in systolic blood pressure of 7.2 mmHg. The placebo group showed a mean reduction of 1.3 mmHg. That is a net difference of 5.9 mmHg, close to 6 points of systolic pressure, from a beverage that costs under 30 cents per serving. The p-value was 0.03. Translated out of statistical language, roughly a 1 in 33 probability that this result occurred by chance. For a dietary intervention in a 6-week outpatient trial, that is a meaningful, replicable signal. And the subgroup analysis adds another layer. Participants who entered the trial with the highest baseline blood pressure showed the largest reductions. Systolic readings above 129 at baseline were associated with average reductions of 11 mmHg. The people with the most to gain got the most benefit. That dose-response relationship is exactly what you want to see in a pharmacologically coherent intervention. This is the study that tends to make people do a double take when they read it carefully. Alfredo Herrera Arellano and colleagues, published in the journal Phytomedicine in 2007, a head-to-head randomized trial comparing standardized hibiscus extract against lisinopril, a named ACE inhibitor, in adults with mild to moderate hypertension, not pre-hypertensive, actual diagnosed hypertension. The lisinopril group, average systolic blood pressure reduction of 1158 mmHg. The hibiscus extract group, average systolic blood pressure reduction of 11.58 mmHg. That is not a formatting error. The outcomes were statistically equivalent. Diastolic pressure showed similar equivalence between groups. Adverse effects. The lisinopril group had a higher rate of reported adverse events, primarily the ACE cough that affects somewhere between 5 and 20% of patients, depending on the population studied. This was a single trial. It had limitations: sample size, duration, specific preparation of hibiscus used. I am not suggesting the literature has proven that hibiscus and lisinopril are interchangeable. That would require years of larger trials and mortality data that don't exist yet for hibiscus. What I am saying is this: a peer-reviewed, randomized controlled trial directly comparing the two found comparable antihypertensive effect in mild to moderate hypertension. That result belongs in any honest conversation about the evidence, a completely different mechanism. Same destination. Amrita Ahluwalia and colleagues at the Queen Mary University of London published a study in Hypertension, the American Heart Association's flagship hypertension journal, in 2013. The finding: a single dose of dietary nitrate from beetroot juice reduced blood pressure within 3 hours, not 3 weeks, 3 hours, and the mechanism was measurable. They weren't just reading cuff pressure, they were measuring arterial stiffness via pulse wave velocity, endothelial function via flow-mediated dilation, and plasma nitrite levels. The 2012 meta-analysis by Ciervo and colleagues, published in the Journal of Nutrition, pooled data from 16 randomized trials looking at inorganic nitrate and nitrite supplementation. Mean reduction in systolic pressure, negative 4.4 mmHg. Mean reduction in diastolic, negative 1.1 mmHg. Consistent, reproducible across studies, mechanistically explained in the literature. The Song meta-analysis, published in Hypertension, analyzed 34 randomized controlled trials of magnesium supplementation, pooled result at approximately 300 mg per day of elemental magnesium, systolic blood pressure reduction of negative 5.6 mmHg, diastolic of negative 2.8 mmHg. Effect was more pronounced in individuals who were deficient at baseline, which describes a significant portion of adults in the United States, given that surveys consistently show 50 to 60% of the population below the estimated average requirement for magnesium. 3 pathways, 3 distinct mechanisms, 3 separate bodies of controlled trial data, all pointing toward meaningful, numerically significant reductions in blood pressure from dietary interventions. Here is the number I want you to hold: a 5 to 7 mmHg reduction in systolic blood pressure, sustained over time, is associated in prospective cohort data with approximately a 14% reduction in stroke risk and a 9% reduction in coronary heart disease risk. You don't need to drop your systolic by 30 points to meaningfully change your risk profile. You need to move the number consistently in the right direction over months and years. The magnitude of effect documented in the hibiscus RCT data is not trivially small. It's in the range that epidemiologists use when they model population-level cardiovascular event prevention: a cup of tea, 30 cents, 3 times a day. Now let me show you exactly how these mechanisms work at the molecular level, because this is the part that makes the protocol make sense rather than feel like wishful thinking. Your blood pressure is regulated, in part, by a hormonal cascade called the renin-angiotensin-aldosterone system, or RES. Here is the relevant sequence without the medical jargon. When your body perceives low blood pressure or low blood volume through pressure sensors in the kidneys, it triggers a chain reaction. The kidneys release an enzyme called renin. Renin converts a protein in the blood called angiotensinogen into angiotensin I. Angiotensin I then gets converted by ACE, angiotensin-converting enzyme, into angiotensin II. Angiotensin II is a powerful vasoconstrictor. It tells blood vessel walls to tighten. It also stimulates the adrenal glands to release aldosterone, which tells the kidneys to retain sodium and water, increasing blood volume. The combined effect: narrower pipes, more fluid, higher pressure. ACE inhibitor medications block the conversion of angiotensin I to angiotensin II. No angiotensin II, no vasoconstriction signal, no aldosterone-driven fluid retention. Blood pressure drops. Hibiscus sabdurifa, specifically the dried calyces, which are the red flower parts, contains compounds including delphinidin-3-sambubioside and cyanidin-3-sambubioside, which are anthocyanins. Multiple in vitro and in vivo studies have demonstrated that these compounds inhibit ACE activity. They are not as potent per milligram as pharmaceutical ACE inhibitors, but brewed hibiscus tea delivers a concentrated dose 3 times a day, and the cumulative exposure is sufficient to produce clinically measurable effects, as the McKay and Herrera-Arellano trials directly documented. Additionally, hibiscus has a mild diuretic effect. It reduces plasma volume modestly, lowering the volume side of the pressure equation. This is the same mechanism that thiazide diuretics exploit. One plant, two antihypertensive pathways, ACE inhibition and mild diuresis. This is why, in the Herrera-Arellano RCT, the effect size was comparable to lisinopril. It was working through the same primary mechanism, with a secondary mechanism bolting additional pressure reduction on top. This one is genuinely elegant, and it starts in your mouth. When you consume beetroot or any high nitrate vegetable, including spinach, arugula, and celery, you ingest inorganic nitrate. The bacteria living on your tongue, specifically the anaerobic bacteria in the oral biofilm around the tongue's surface, express an enzyme called nitrate reductase. These bacteria convert dietary nitrate into nitrite. You swallow. In the acidic environment of your stomach, a portion of that nitrite is chemically reduced to nitric oxide. Nitric oxide diffuses through the stomach wall into the bloodstream. It travels to the endothelium, the inner lining of your arteries, and activates the enzyme soluble guanylate cyclase. This enzyme produces cyclic GMP, which signals smooth muscle cells in the arterial walls to relax. Relaxed smooth muscle means a wider arterial diameter. Wider diameter means lower resistance to blood flow. Lower resistance means lower pressure. This is vasodilation, and it's fast, measurable within 2 to 3 hours of a single dose of dietary nitrate, as Ahluwalia demonstrated. This has a practical implication that most people miss completely. If you use an antiseptic mouthwash before drinking beet juice, you kill the oral bacteria that convert nitrate to nitrite, and you lose a significant portion of the blood pressure benefit. This has been directly tested. Gavoni and colleagues demonstrated this in a crossover study where antiseptic mouthwash use abolished the plasma nitrite rise after beetroot juice consumption. Your oral microbiome is literally part of your cardiovascular system. Kill it with Listerine before your morning beet juice, and you've canceled your own protocol. This is the mechanism that almost nobody frames clearly when they talk about blood pressure and beverages. It's the most important thing I can show you today, not because of what you should add to your water, but because of what you should stop putting in it. When you consume sugar, sucrose, high fructose corn syrup, the sweeteners in most commercial beverages, your blood glucose rises rapidly. Your pancreas releases insulin to manage that glucose. Insulin, in addition to its role in glucose metabolism, directly signals the kidneys to retain sodium. More sodium retained by the kidneys means more water retained to maintain osmotic balance, which means higher circulating fluid volume, which means higher blood pressure. That's the first mechanism. The second mechanism involves nitric oxide. Chronic insulin elevation from repeated sugar intake across a day has been associated in the research with reduced endothelial production of nitric oxide. The endothelium of your arteries uses an enzyme called eNOS to produce nitric oxide. Insulin resistance, inflammation, and oxidative stress all impair eNOS activity. Less eNOS activity means less nitric oxide. Less nitric oxide means less vasodilation. Less vasodilation means higher resting vascular resistance. Higher resting vascular resistance means higher blood pressure. The fructose component of sugar, roughly half of table sugar and almost all of high fructose corn syrup, adds a third mechanism. Fructose is metabolized primarily in the liver. During high-load fructose metabolism, the liver produces uric acid as a byproduct. Elevated uric acid directly impairs endothelial nitric oxide bioavailability. A 2014 study in the American Journal of Hypertension showed that elevated uric acid from fructose overconsumption independently predicted higher blood pressure in a dose-dependent manner. 3 molecular sequences, all triggered by the sugar in the beverage you might be drinking right now as a healthy choice. And this brings me to the label reading moment. Pick up a 20-ounce bottle of vitamin water. Any flavor. The mainstream, widely sold version you find in grocery checkout coolers and gas stations next to the health food display, the front of the bottle says vitamin enhanced water beverage. It is positioned through color coding, vitamin listing, minimalist clean design, and the word water in the name as a hydration and health product. The label lists vitamins, multiple vitamins in meaningful sounding amounts. It looks, in short, like a good choice for someone paying attention to their health. Now turn it around. Total carbohydrates, 32 grams per 20-ounce bottle. Total sugars, 31 grams. 31 grams of sugar in a bottle of water. To put that in concrete units, 31 grams of sugar is approximately 7.75 teaspoons of sugar in one drink. That's more sugar than a standard Oreo milkshake serving from some fast food chains. The American Heart Association recommends no more than 25 grams of added sugar per day for women, 36 grams for men. One bottle of vitamin water gets most of the way there before lunch. Now walk through the molecular cascade. You drink it. Glucose absorption is rapid. No fiber, no fat, nothing to slow it. Insulin spikes. Kidneys get the sodium retention signal. Sodium retention increases fluid volume. Fluid volume drives up blood pressure. Meanwhile, repeated daily exposures across weeks and months are impairing ENOS activity and degrading endothelial function. Uric acid from the fructose component is clipping nitric oxide bioavailability at the arterial level. The vitamin water is running your blood pressure in exactly the wrong direction. Now compare unsweetened hibiscus tea, same serving volume, sugar content, 0. Calories, approximately 7 from trace plant compounds. ACE inhibition, documented in 2 randomized controlled trials. Diuretic effect, documented. Antioxidant protection of the endothelium, documented in vitro and animal studies. Cost, 25 to 30 cents per serving. The vitamin water costs $2.49 at a convenience store and is triggering an insulin cascade that retains sodium and impairs nitric oxide. The hibiscus tea costs 30 cents and inhibits the enzyme that your cardiologist is targeting with a prescription medication at a comparable magnitude in mild hypertension per a published head-to-head randomized controlled trial. The irony is not subtle, and this is not a unique failure of one brand. It is a category-wide issue. The enhanced water market, including Smart Water Alkaline, various electrolyte-enhanced waters with added flavors and sugars, and flavored coconut waters with up to 20 grams of sugar per serving, is built on the visual and naming language of hydration and health while frequently delivering metabolic loads that undermine the cardiovascular system you think you're supporting. I am not saying do not hydrate. I am saying know what is in the bottle before you drink it as a health choice. The rule I use when evaluating beverages in the context of blood pressure. Does this drink have a documented mechanism for reducing vascular resistance, or does it have a molecular pathway that increases it? Plain water, neutral. Hibiscus tea, ACE inhibition. Beet juice, dietary nitrate to nitric oxide. Sparkling water, neutral. Sweetened vitamin water, insulin-mediated sodium retention, plus endothelial nitric oxide impairment. Sports drinks, high sugar plus sodium, double mechanism for raising pressure. Commercial orange juice, high fructose uric acid pathway, elevates pressure via the mechanism I described above, despite the potassium. Once you have this framework, reading a beverage aisle takes about 90 seconds, and you will never buy vitamin water again. Now, I want to walk you through exactly what the research supports as a practical, affordable, and mechanistically coherent protocol for blood pressure management through what you add to and remove from what you drink. But first, the second disclaimer, because this section gets into specifics and that requires precision. Everything that follows is meant to complement, not replace, your medical care, especially if you're on warfarin, clopidogrel, or aspirin. Some of these interventions, particularly nattokinase, high-dose vitamin K2, and fish oil, can interact with anticoagulants. Bring this to your cardiologist before starting. And specifically on blood pressure, If you are already on antihypertensive medication and you add hibiscus tea, your blood pressure may drop further than your medication was designed to handle alone. That is not a danger notice to avoid hibiscus. It is a reason to monitor your blood pressure at home and to have a conversation with your physician if your numbers shift significantly. Get a home blood pressure monitor before you start this protocol. They run $25 to $35 at any pharmacy. Check your readings at the same time each morning and each evening. Keep a log. Not forever, just for the 6 weeks of the active protocol. If your numbers drop meaningfully, that is data. Bring it to your doctor. That data-grounded conversation is how things actually change. This is the best evidenced intervention in this entire protocol. Hibiscus subdurifa tea, unsweetened, 2 to 3 cups per day. The specific protocol from the McKay 2010 study, 240 milliliters, 1 standard 8-ounce cup, brewed from dried hibiscus calices for 5 minutes in near boiling water, 3 cups per day. No sweeteners, no additives in the first 2 weeks if you want to isolate and measure the effect. What you're buying, dried hibiscus calices, not hibiscus-flavored blends with other ingredients, not hibiscus extract in a proprietary supplement with a markup, just dried hibiscus flowers. You can find these in bulk at Latin American grocery stores where they're sold as Flor de Jamaica, at health food stores, and online. A half-pound bag typically runs $6 to $12 and will last 4 to 6 weeks at this dose. That math comes out to 25 to 30 cents per serving, or roughly $7 to $9 per month. A standard 1-month supply of lisinopril with insurance typically costs $30 to $80 depending on your plan. Without insurance, generic lisinopril is often $10 to $30. The hibiscus is cheaper in both comparisons. The flavor profile, tart. Cranberry adjacent. A lot of people genuinely enjoy it. Cold hibiscus tea over ice in the afternoon is not a hardship. If the tartness is too aggressive, you can add a small squeeze of lemon, which adds hesperidin flavonoids with mild additional vasodilatory effects. Timeline of expected effects. Based on the McKay trial data, measurable systolic reduction begins around 2 weeks and reaches maximum effect by 4 to 6 weeks. This is not a supplement you take once and feel a difference. This is a sustained biochemical input to an enzyme system. You are inhibiting ACE. ACE inhibition takes time to shift baseline vascular tone. Expected magnitude. If your baseline systolic is in the 130 to 149 range, the research suggests 5 to 11 mHg systolic reduction is plausible. If your baseline is lower, the effect will be smaller, which is appropriate and expected. You cannot use hibiscus tea to drive blood pressure below your normal range the way misuse of pharmaceutical ACE inhibitors could. Drug interaction note. If you are already on an ACE inhibitor, you are stacking ACE inhibition on ACE inhibition. Your blood pressure may drop more than expected. This is a conversation to have with your cardiologist, not a reason to avoid hibiscus. But please tell your doctor what you're doing. Also worth noting, hibiscus is high in oxalates. If you have a history of kidney oxalate stones, discuss this with your physician before consuming 3 cups daily. For most people, this is a non-issue, but it's worth knowing. And a note on hibiscus and iron absorption. The tannins in hibiscus can mildly reduce non-heme iron absorption if consumed at the same time as iron-rich foods. If you are iron deficient or anemic, drink your hibiscus tea away from meals rather than with them. This is a minor practical note, not a contraindication, but it's the kind of thing that gets left out of supplement marketing and belongs in an honest discussion of the research. The dietary nitrate protocol, completely different mechanism from hibiscus, which means these 2 interventions are potentially additive. Protocol: 250 milliliters of cold-pressed beetroot juice in the morning, or 1 level tablespoon of tested, non-heat-destroyed beet powder dissolved in 250 milliliters of water. Daily. One important quality note on beet powder. The nitrate content, and therefore the nitric oxide producing capacity, varies significantly by product. High-temperature processing destroys the bacterial enzyme pathways and can degrade nitrate content. Look for cold-processed or raw beet powder. Better yet, cold-pressed beet juice is the gold standard for preserving the nitrate to nitrite conversion pathway. Cost comparison. Fresh beets from a market, juiced at home, run approximately 50 cents to $1 per medium beet. A cup of fresh beet juice requires 2 to 3 medium beets, roughly $1.50 to $3 per serving. Cold-pressed commercial beet juice runs $3 to $5 per 250 milliliters. A quality beet powder supplement is typically $20 to $30 per month for daily dosing. The fresh juiced option is cheapest long-term if you have a juicer. The powder is most convenient. One note you should know before you start. Beets cause a harmless condition called beeturia. Your urine and sometimes stool turns red or pink. This happens in roughly 10 to 14% of people and is more common in individuals with lower stomach acid. It is completely benign. Mentioning it because the first time it happens without warning tends to cause alarm that is entirely unnecessary. Expected effect: negative 4 to 6 mmHg systolic sustained over daily use for 2 to 4 weeks. Acute effect from a single dose is measurable within 2 to 3 hours, but the sustained benefit requires daily intake. Do not use antiseptic mouthwash on mornings when you're using the beet protocol. That kills the tongue bacteria, doing the nitrate to nitrite conversion and substantially reduces the cardiovascular benefit. This has been directly measured in a crossover study. This intervention costs nothing. It saves money. And the mechanistic rationale, detailed in the insulin sodium uric acid nitric oxide cascade I described, is well supported in the literature. If you currently consume sodas, sweetened iced teas, sports drinks, commercial juices, or enhanced waters of the vitamin water type on a regular basis, replacing those with unsweetened beverages is a physiologically meaningful blood pressure intervention, not through direct pharmacological action, but by removing an active molecular input that is pushing your pressure upward. This is a subtractive protocol. You are not spending money. You are not adding a new habit. You are removing an input that the research links to sodium retention, endothelial dysfunction, and elevated uric acid, all of which contribute to higher blood pressure. Replace with plain water, unsweetened sparkling water, hibiscus tea, which serves double duty here, both removing the sugar and adding the ACE inhibition. Unsweetened green tea or black coffee without added syrups. For the 6 weeks of the active protocol, treat this as non-negotiable. Then track your home blood pressure readings. I want to lay this out side by side, clearly, because this is the most important structural comparison in this entire video. I am not arguing that hibiscus replaces medication. I am showing you what the research actually puts next to each other. ACE inhibitor medications: lisinopril, enalapril, ramipril. Average systolic reduction in mild to moderate hypertension, 8 to 12 mmHg. Monthly cost, $30 to $100 with insurance depending on plan, $10 to $30 without insurance for generics. Side effects: persistent dry cough, ACE cough, in 5 to 20% of patients, more common in East Asian populations. Dizziness on standing, particularly in older adults. Rare cases of elevated potassium, particularly relevant in kidney disease. A rare but serious side effect called angioedema, swelling of the face and throat, occurs in less than 1% of patients but requires immediate medical attention. Evidence base: decades of large-scale trials, strong mortality outcome data in heart failure, diabetic kidney disease, post-MI patients. Hibiscus tea, Hibiscus sabdarifa, unsweetened, 2 to 3 cups daily. Average systolic reduction per RCT data, 7 to 11 tabani mmHg. Monthly cost, $5 to $10. Side effects in trial data, minimal. Rare reports of GI discomfort. No significant adverse events in published studies at standard doses. No documented angioedema risk. Evidence base: multiple RCTs, one head-to-head against lisinopril with comparable outcomes. No long-term mortality outcome data. This is a genuine limitation. The framing that matters: ACE inhibitors are necessary, evidence-based, and appropriate for many people, especially those with established cardiovascular disease, heart failure, chronic kidney disease, or stage 2 hypertension that has not responded to lifestyle modification. I am not here to talk anyone out of their medication. The conversation the research supports is this one. If you are in the pre-hypertensive or stage 1 hypertensive range, if your cardiologist is watching the number but has not yet committed to prescribing, if you want a tool with a documented mechanism and real trial data to use in that window, hibiscus tea is exactly that tool, and it costs 30 cents a day. Potassium is the dietary complement to sodium in the pressure equation. When potassium intake is high, the kidneys are stimulated to excrete more sodium, which reduces fluid retention and lowers blood pressure. The meta-analytic data on potassium and blood pressure is consistent. A systematic review by Alberto and colleagues in the BMJ in 2013 found that higher potassium intake reduced systolic pressure by negative 3.49 mmHg on average. High potassium foods that are free or very low cost: bananas at approximately 20 cents each, sweet potatoes at 80 cents to $1.50 each, avocado, white beans, lentils, dark leafy greens. These are also the foods that happen to deliver the nitrates and magnesium from priority 2 and the additional mechanisms above. There is significant overlap by design in the DASH diet framework, the dietary approach that the National Heart, Lung, and Blood Institute has been promoting for blood pressure since the 1990s, which has its own strong RCT evidence base. Magnesium. If you are not regularly consuming magnesium-rich foods, dark leafy greens, nuts, seeds, legumes, the Song 2016 meta-analysis supports supplementation at 300 milliliters of elemental magnesium per day. Magnesium glycinate or magnesium malate are significantly better absorbed than magnesium oxide, which is the cheap form in most bargain supplements. Cost for a quality magnesium glycinate, $10 to $15 per month. Effect: approximately negative 5.6 mHg systolic, negative 2.8 mHg diastolic per the pooled RCT data. Home blood pressure monitor, systolic and diastolic twice daily, same time each day. Morning reading before coffee, before any medication, after 5 minutes of seated rest. Evening reading before dinner, log both numbers. Do this for 7 to 14 days before you start the hibiscus protocol so you have a clean baseline. Then continue throughout the 6-week intervention. You are looking for a downward trend in your morning systolic readings over weeks 2 through 6. The effect is not linear. It is cumulative and gradual. Single-day readings can be noisy. What matters is the 7-day rolling average. For those who want to go further, hsCRP, high-sensitivity C-reactive protein, is a marker of systemic endothelial inflammation that correlates with arterial health. A reading above 3.0 mg/L places you in elevated cardiovascular risk territory, independent of your cholesterol numbers. It is a standard blood test available at any lab. Ask your doctor to include it at your next visit. A well-executed dietary nitrate and polyphenol protocol, hibiscus, beets, leafy greens, should also move hsCRP downward over 3 to 6 months if you sustain it. Let me tell you what happens in most people's relationship with their blood pressure numbers. They get a high reading at the doctor's office. They're anxious that day. They know white coat effect exists, so they discount it slightly. They get the prescription recommendation. They hesitate either out of concern about lifelong medication, side effects, or cost. They Google alternatives and land on a mixture of well-evidenced research and complete nonsense. And they can't tell the difference without a background in interpreting clinical trials. Then they do nothing because the conflicting information creates paralysis, and their blood pressure stays where it is, or climbs. That cycle frustrates me more than almost anything in the cardiovascular research space. The evidence base for dietary blood pressure management is not thin. It is not fringe. It is published in the same journals that publish the pharmaceutical RCTs. The problem is that the packaging of that evidence has historically been either overly academic or contaminated by supplement marketing that makes legitimate findings look like sales pitches. So let me package it plainly, the way I would tell a colleague. The 67-year-old at the Tufts study did not discover a miracle. There are no miracles in the cardiometabolic literature. What he found was a well-characterized plant compound with a documented molecular mechanism applied consistently 3 times a day for 6 weeks. The result aligned with what the controlled trials predicted. That is not magic. That is science doing what science does. Blood pressure management has been framed for the better part of 3 decades as primarily a pharmaceutical conversation. See your doctor, get the prescription, take the pill, manage the number, and that framing is not wrong. ACE inhibitors save lives, and the evidence base behind them is not in question, but it is incomplete. The McKay 2010 study, the Herrera-Arellano 2007 head-to-head, the Ahluwalia 2013 nitrate data, the Song 2016 magnesium meta-analysis. These are not findings from journals nobody has heard of. These are the Journal of Nutrition, Phytomedicine, Hypertension, the BMJ. These are the journals that cardiologists cite. These findings belong in the clinical conversation, and increasingly, they are. If your blood pressure is creeping up and you're waiting for permission to do something other than wait for the prescription, this is that permission from the literature. The protocol is this: 2 to 3 cups of unsweetened hibiscus tea per day brewed from dried hibiscus calyces. 1 cup of cold-pressed beet juice or beet powder in the morning if you want to layer the nitric oxide pathway on top. Remove the liquid sugar, the sodas, the juices, the vitamin water, because every ounce of that sugar is working against the same pressure mechanisms you're trying to improve. Add potassium through food. Consider magnesium supplementation at 300 milligrams of the glycinate form. Get a home blood pressure monitor. Establish your baseline. Track for 6 weeks. And here is the thing I most want you to remember. The primary intervention in this protocol costs 30 cents a day. Not $30, 30 cents. The comparison beverage, the one that is actively raising your blood pressure through the insulin sodium uric acid cascade, costs $2.49 and has the word water in its name. That gap between what the marketing suggests and what the molecular biology does is where a lot of people's blood pressure problems live. You now know the difference. There is one more thing I want to say before I close, and it's about the framing of natural versus pharmaceutical, because that framing is usually a trap. The drugs are not bad. The tea is not magic. What exists is a spectrum of interventions with different evidence profiles, different cost structures, different side effect profiles, and different appropriate applications depending on your baseline physiology, your disease stage, and your treatment goals. Hibiscus tea at 2 to 3 cups per day is appropriate for pre-hypertension, stage 1 hypertension in people not yet on medication, as an adjunct to lifestyle modification during the watch and wait period, and potentially as a complement to pharmaceutical treatment in consultation with a cardiologist. It is not appropriate as a standalone replacement for medication in people with stage 2 hypertension, established cardiovascular disease, heart failure, or diabetic nephropathy. Those patients need the mortality outcome data behind ACE inhibitors. The tea does not have that data yet. Know where you are on that spectrum. That knowledge is what makes the research useful rather than just interesting. One final note for anyone already on blood pressure medication: do not stop taking it based on anything you watch today. That would be the wrong takeaway. What I'd suggest instead is this: start the hibiscus protocol. Track your home readings daily. Give it 6 weeks. If your numbers improve measurably, and the trial data suggests they might, bring your blood pressure log to your cardiologist. Let the data do the talking. That is the conversation worth having. That conversation, grounded in numbers you measured yourself at the same time every morning, is where things can genuinely change. The research is clear. Start with hibiscus tea.